End-of-life care has been characterized by aggressive medical intervention and runaway costs, but it doesn't need to be. End-of-life care has been characterized by a culture and systems that contributed to unnecessary emotional and financial burdens for patients and their loved ones, but it doesn't need to be. Since the early 1990s, the Jewish Healthcare Foundation has invested over $50 million in a range of strategies and initiatives that focuses on quality of life for older adults and for those nearing the end of life.
Our foundation has a tradition of taking on the edgy topic, the topic that others might not want to touch, but the death panel discussion activated it, and we decided people had to have conversations that weren't charged, that weren't political.
JHF has developed a rich portfolio on the subject of end of life, all under the umbrella of closure. Newsletters, websites, manuals, a nationally recognized PBS special, creative nonfiction, and statewide conferences.
Our goal with Closure was to make sure that we could put the systems in place to provide the education and training for family members and for healthcare providers so that they could have an opportunity to do for people at end of life that which was appropriate, compassionate, and which met everybody's needs.
We hear all the time that most people say they don't want to die in the hospital, they want to die at home, and yet the majority of people die in the hospital and a good chunk of those people die in the ICU. Modern medicine's great, but it's not all powerful. The closure model is a way of bringing people to the table and starting the discussion so that they can then have a conversation about themselves, about their community.
When we're talking about end-of-life care, end-of-life wishes, advanced directives, this is how I often hear physicians or family members talk about it. So, what would you like, Mrs. Smith, if something catastrophic were to happen? Would you like us to do everything? Now, if I was Mrs. Smith, I would answer that question, why, yes, I would like to do everything. And what the person asking usually means is, would you like us to do everything possible to rescue and bring you back from the precipice so that you can live longer? Would you like us to rescue you from this process, from this disease? And what Mrs. Smith thinks is, if I say, no, I don't want you to do everything, you're going to abandon me. You're going to do nothing.
But not everyone chooses to be rescued.
I just like to stay at home.
Okay.
I've had enough hospitals.
Okay, right.
The closure model, which is entirely customizable to the audience, consists of 6 sessions, or structured conversations, that deal with various topics. There are companion pieces such as the closure manuals, which provide guidance on how to conduct the series in your community, and if you want to supplement that with online learning, there are educational modules specific for patients and families, as well as healthcare professionals at closure.org.
I would say, despite the fact that I thought I was bringing a lot of sophistication to the program, it's really been one of the most interesting things that I've done professionally, certainly since I came to Pittsburgh.
It was only when I began to work with the Jewish Healthcare Foundation and the Closure Initiative that I began to really understand what does it mean to help people. Closure has allowed me to gain clarity over how much we should value every single day of our lives, even to the end, knowing that the most important part is quality of life.
2 physicians who have been involved with JHF and the Coalition for Quality at the End of Life since the beginning are Drs. Judy Black and Bob Arnold.
So if we start with what's important to the patient and then have informed decision-making, collaborative decision-making, we'd have a very different system of care for those of us at end of life.
And so I think that this is a unique time to try to help all patients understand what their choices are. Some of it's going to be to understand what the limits of medicine are. There are limits to medicine.
After participating in the Closure series, one skilled nursing facility saw an expanded role for the nursing staff.
We're going to pull you over a little bit, okay? During the closure meetings, one doctor spoke up and said he has a very difficult time having closure conversation with the family, and he would like assistance from the nursing staff. That was an eye-opener for everyone.
The success of and interest in the Closure series led to 2 widely distributed and nationally recognized pieces: creative nonfiction's At the End of Life,
Can I have my hug?
and the WQED PBS documentary, The Last Chapter. At the End of Life is a collection of personal stories written by sons, daughters, parents, and medical professionals, exploring death, dying, and palliative care. The Last Chapter documentary, nominated for a Golden Quill Award, follows several people with terminal illness in their journey toward writing their last chapter. The annual Fine Awards, co-sponsored by JHF and the Fine Foundation, selected End of Life and Palliative Care as the application topic in 2013. The finalists mark some of the most heartwarming stories that we've seen about how you can improve care for those in the final stages of life. Training those who are caregivers, having that all-important discussion with the patient and the family, training the medical professionals, and helping someone remain active and involved.
We believe that a sophisticated healthcare response for individuals with serious disease will find a balance between cure and care through end of life.
Being able to write the last chapter in a way that's meaningful for you, being able to get meaning instead of just more suffering out of those last few days or weeks or months.
The end of treatment targeted against the disease doesn't mean the end of care.
I want it to be so much more than adding a few days or hours, much more about adding meaning.
For more information, please visit closure.org.